I was just doing a colloid fist, so I was just stuck up trying to stop the bleeding, which was coming from underneath, but it was fine then eventually. That's why I was just delayed. Sorry. Um, well, it's wonderful to be part of such a brilliant idea that Nicolay had. I wish we were there in person, but hopefully we can do that some other day. I congratulate Nicolay and the directors for running such a wonderful show and getting all the elite people from around the globe. There's lots been happening regarding innovations in spine care. So what I'm going to do is just take you briefly through what has recently happened. So over the past 50 years, there's a lot of hype regarding spine surgery, and success rates have changed as well. And this could be due to the advancements in surgical techniques and integration of new technologies aimed at enhancing patient care. Innovation in this context refers to the process of enhancing value or driving change to boost an enterprise economic or social impact. So I think economic is one way, but I think it's huge social impact on top of it. Um, so changes in WHO CNS5, these are one of those changes which has made a difference with the spinal ependymomas, including subependymomas and myxopapillary. So now we know that there's rare spinal ependymomas that have amplification of MYCN oncogene, an aggressive clinical course. They're completely different. And the rare examples are in adolescent and are reported in infants and children. And these are the ones that you should be careful about, and a different kind of treatment regime is required for them. Advance in diagnostics has changed quite a bit. Conventional things are same, X-ray, CT, MRI, PET, but there's Softmax and Nucleus Max that is already available. We have better pre-op planning, or that's what we think, intraoperative advanced tools and improved post-op care. So Mimics, Dolphin Imaging, Maxilim, they are all known as medical CAD software were used in this study. And they concluded that virtual preoperative simulation using AI software directly could be helpful in predicting the actual surgical procedures. So they could predict exactly what the lesion was, and what kind of invasiveness, and then the surgical procedure itself, and also on the outcomes. So this all is already out there with a lot of AI softwares that we have. So something like this, you load the file and you come up with your lesions, and obviously the software automatically with thresholding looks up what is bone, what is tumor, what is soft tissue, and they automatically come up with a plan, and we automatically get to know how we're going to do things, and then it tells you what procedure may be the best. Roger Hartle and group published this in 2022. Virtual reality in neurosurgery beyond neurosurgical planning has been shown by many people. So what is the difference between virtual and augmented reality? We all know this, but let me just quickly go through it. Virtual reality is when it's immersed in computer-generated environment. There is no real input, whereas in augmented reality, virtual object is overlaid on the real environment. So just like when we are doing some computer-guided surgery, all we do is wear Google glasses or something of a similar variant. And you can see in real world enhanced with digital objects. So application in neurosurgery and simulations have been various, as you can see here. So there are models for augmented reality, pre-surgical planning, ventriculostomy, the models to do various operations when these simulations, and they all have been tested and reported over the last decade. So, for example, this patient is using the augmented reality, wearing these glasses. So you can see exactly where the tumor is. You can see exactly which part you're going into, and you can plan accordingly where you are. You can put in screws accordingly. At the same time, remove the tumor and ensure that you've gone into a cyst before you're going into an intramedullary lesion before attempting to get into the tumor itself. And then you can see various things. You can see the bone, you can see the ligaments, you can see the vessels, and then you can plan accordingly. It makes life much easier. So for example, in something like when we are doing a invasive lumbar hemilaminectomy, then we see that you have this head-mounted camera, and there is no augmentation. This augmentation of the spine itself, and then you just do a wire mesh overlay. And we have many various ways of improving this with the help of this overlay vertebroplasty needles, etc., which can give you exact trajectories where you're going to be doing vertebroplasties, and even in brain itself that you can do many things. So there are hybrid operating theaters or something like this, in which you can put in angio, MR, CT, and many things that you can use and work along in the real time sense. Then what about the MIS-assisted robotic spine surgery? Well, at the moment, we think that it is only an expensive drill where the accuracy is probably slightly more than usual. But at the same time, now more and more people are using it, and the way forward is going to be interesting, because already there are many systems available by which you can even drill part of it. At the moment, obviously, it's not tested in big way, but there are people who are using it. And hopefully in near future, we'll be able to drill really safely with the help of a robot itself. This percutaneous CT-guided microwave ablation combined with CT, for example, if you've got a tumor, you've got vertebral metastasis, so you can ablate, and at the same time you can do percutaneous vertebroplasty or kyphoplasty, whatever you want to do, and put in pedicle screws in the same setting. So for example, in the 65-year-old, same thing was done and applied everything at one time. So it is possible to improve things. So you've got a microwave ablation along with combined pedicle screws followed by vertebroplasty. What about resection without K-wires? Now, this has become a routine that, many a time when we're doing image guidance with robot, etc., then we don't use K-wires, and, the way forward is only one way of doing it. It's a single step screws. Application of carbon fiber has been there for a while, and it's because when you do our scans with titanium or other metal, then we cause problems, artifact, and can't see much. And this has been a way forward for our tumor patients. Post-op cares, as the concept of ERAS is there, where preoperatively we plan analgesia, nutrition, fasting, patient education. Intraoperatively, we look at choice of anesthetic agents for induction, maintenance, using non-opioid analgesia, maybe giving some kind of block beforehand so that there is anesthesia along with blocks, so that these patients require a little kind of treatment afterwards, and so do not require large doses of analgesia post-op. Obviously, early embolization, physical therapy, nutrition intake, wound care, and pain management, and all that should be a routine part of any center, has evolved over time. Radiotherapy has changed in many ways. Stereotactic body radiation therapy was changed by IMRT, followed by proton beam therapy. And research has shown that targeting precisely tumors is much more accurate with proton beam, and image-guided radiation therapy is equally effective, and new thing that has come in. Also, immunotherapy in combination with radiotherapy has shown really wonders, and slowly and gradually targeted immunotherapy is also the way forward. Functional imaging leading to adaptive radiotherapy has been excellent as well, and has shown to improve the outcome in some patients. So percutaneous hybrid therapy for spinal metastasis, laser interstitial thermal therapy, and spinal stereotactic radiosurgery in combination could be used. So you have got the spinal stereotactic radiosurgery in the form of radiation, delivering in various ways. So intensity modulated radiotherapy combined with image guidance and rigid immobilization could be done at the same time. SSRS offers durable local control, pain relief for in carefully selected patients. The ability of SSRS to deliver an ablative dose of radiation to METs has changed treatment paradigm when used as definitive therapy as a post-operative regimen. Based on improved responsive, surgery has largely transited from an aggressive gross total in-block resection to less aggressive approach aimed at spinal cord decompression in order to allow clearance. for treatment with the tumoricidal doses of radiation to the residual disease while respecting the radiation constraint of the spinal cord. Spinal interstitial thermal therapy, as shown before, has been developed as minimally invasive percutaneous method through open surgery. It can be performed in selected cases of epidural metastasis in combination of SRSs. So, for example, intraoperative, you have a patient like that, you've got fiducials put in, you get an MR, and with the help of MRI, you can plan where your screw or your ablation is going to happen. And then you can finish the job in one go. So it is an alternative to open surgery in selected cases of epidural spinal compression. Laser fibers are placed under MRI image guidance. It can be performed with minimal surgical morbidity, giving the correct patient selection and allows fast recovery, avoiding the transitional 2 to 3 weeks of convalescence. Comparison between equivalent cases treated with open surgery and SLIT have shown no difference in respect to local tumor control, but obviously there are other significant advantages that are there. I talked about microwave thermal ablation. Well, this works like that there is an electromagnetic field with about 915 megahertz or 2.45 gigahertz. It's targeted through an antenna onto the tumor, and then electromagnetic field induces continuous rearrangement of dipole in primary direction, forcing the polar molecules, primarily water, within the tissue to continuously rearrange with oscillating electrical field. This increases the kinetic energy of the molecule and increases the temperature, leading to coagulation necrosis. So it's basically causes coagulation necrosis through this process. So it has been shown to be feasible and effective procedure for pain relief in patients with refractory painful spinal tumors. Immediate pain relief was followed by only one procedure, and pain relief lasted 6 months. High-dose single-fraction image-guided intensity modulated radiotherapy for metastatic spinal lesions. So delivered dose, the radiation dose appears to make a difference. So, you can use hyperfractionated, you can use single fraction, and IMRT is ideal for creation of concave dose distribution necessary for cord-sparing treatments. Thermal ablation and augmentation has been there for some time, but more and more of it's being used in metastatic patients. So goal of LIT is selective thermal injury of pathological tissue while maintaining a sharp thermal border between tumor and the normal tissue. So currently available systems are NeuroBlate and Visualize. What about AI? Well, artificial intelligence refers to technologies that interpret and analyze data in the way that mimics human cognitive function. It's difficult to comprehend, but slowly and gradually it's getting there. AI's role in automating image interpretation appears to have its largest current clinical application in spine surgery. It is able to calculate spinopelvic parameters and other pelvic, cervical, thoracic parameters and automatically segment vertebra for its end users. So basically, it can tell you beforehand that what kind of screws you need to put in, how much of deformity you need to correct, and it has built-in age in it as well, so that you're not trying to correct kyphosis in old age group, etc., or deformity of some kind. And it's excellent reliability and accuracy compared to expert human measurements. It has the ability to both classify image using existing scheme as well as new system based or on self-directed data set learning. It can accurately grade spinal stenosis, lumbar disc prolapse, etc. on MR, and there are various pathologies that now are being included. Next, novel sparse language mode for Chinese radiology's report summarization. So it's basically successfully and accurately diagnosed spinal metastasis, and the accuracy is up to 96.5%. It was worthy of being used in early diagnosis of the disease. What about artificial intelligence and predicting modeling in spinal oncology? So what you do is you have image acquisition, image processing, image-based tool, and you report an integrated diagnosis. So it differs the whole thing. And then with the detection of the tumor, you can characterize what kind what segmentation, what kind of diagnosis, what stage it is. And then it comes up with the decision support, includes radioeconomics, phenotyping, monitoring, and treatment planning, and predicting outcome. And you can add that to with the help of your knowledge and your experience, and have a huge output with these patients. It's just like using image guidance. You know where the lesion is in some cases, but image guidance helps you to get there more precisely. What about brain-machine interface? This has been there for a while, but hasn't taken off in big way because of the cost involved. The integration of brain-machine interface to neuroprosthesis provide an innovative approach to aid patients with sensory motor deficit. BMI works on the principle that neural activities in brain are associated with intended movement trajectories, even in the absence of actual movement. So you can see, this kind of electrodes that are put in, and you can record, and you can have brain penetrating micro electrodes which can record and then pass the signal on to wherever we want to pass. So for example, bypass cortical commands over the lesion side to the appropriate you to control your wheelchair, your computer, voice, etc. So there are many things that can be done with the help of this brain-machine interface. What are the types? There is functional type, invasiveness, depending on origin of the neural signal, and BMI design. So for example, you've got a patient with spinal cord injury, with low-level spinal cord injury paraplegia. So a device implemented helps bypass beyond the injured side and aids in walking with electrical stimulation. So that's put on flexion and extension. So then patient is put in a robot, and that robot gives exercises in conjunction with the stimulation that we have. And these patients, majority of them, are able to walk after that with the help of this really expensive exercise. So electrodes may be implanted in brain for control of various objects, for example, a wheelchair, a hand, a leg movement, etc. And for example, epidural area stimulation causing stimulation below the site of injury, and then sequential stimulation of flexion and extension with the help of a harness or and detecting movements by a camera. And with the help of that, it is possible for these patients to improve in some ways. So people who would never walk are able to walk with the help of that. FDA authorizes the first brain-computer interface device. And this is robotic wearable ipsilateral IPSI hand. It can help people with stroke. And this works with two parts, a wireless exoskeleton and a non-invasive EEG control. We wrote this article 4 years ago, in which we talked about I Felt the Ball, which was Pinto, who was a footballer, and then in the Mexican Olympics or Mexican World Cup, he kicked the first ball, and he was what the surgeon did was switched on the sensory element in the feet, and he kicked the ball with the help of motor stimulation. And the only thing he could think about is say, I felt the ball. And so this was amazing for him that, after so many years, he was able to feel the ball. The future of BMI with fusion of robotics and artificial intelligence is promising for patients with chronic spinal cord injury. These modern devices need to be less invasive, biocompatible, easily programmable, portable, and cost-effective. After these hurdles are overcome, these devices could be mainstay of potential rehabilitation therapy for partial recovery of these patients. The time may come when all patients with spinal cord injury are told, you will walk again. Well, and then we look at this immunotherapy for pediatric brain and spine tumors. So Chada looked at this H3.3 K37M specific T cell response and creating a vaccine, and with the help of vaccine coming up, injecting that vaccine in these patients and coming up with a specific module in which they're able to treat these patients more effectively. So it's been really my pleasure, and hopefully we will be part of all these innovations in near future. And maybe Nikolay and Mirza could throw some light on these. Thank you.
Thank you so much, Salman. It was a great presentation. And I think we decided to leave the questioning for the end. I think you have one more presentation today. When do you want
Yeah,
to?
can I do that in 15 minutes? If that's okay?
Well, okay, so I'm gonna present then a short poster, and after that, it will be Kim, and then if you want to jump in after that, that'll be perfect. Would that work?
Brilliant. Oh, or how long will you be? 10 minutes?
Well, Kim likes to talk, so probably will be.
Oh, no. So let me come before Kim. Okay. So how about, you'll be done